Okay, so we're here today to talk about complex nursing care. So what are we talking about really? What we're presenting is about the fact that when we look after patients, things can be simple. They can have a dose of the chicken pox, but not only do they have a dose of the chicken pox, which means they're infectious, they have all the other things that go with it. So they might have wounds from the little pock marks, so there's a risk of infection. So it's not just a matter of they've simply got chicken pox. They've got itching, they've got pain, they've got discomfort. So we have to take that into consideration when we actually look after our patients, and most care we do is complex because it's involved. But how do we deal with that? We involve others. So we'll talk a bit about the nursing team. So and it's talking about complex needs. So how do we deal with it? So there's pain relief, there's relief from the scratching, there's antibiotics, so there's side effects from antibiotics, there's side effects from pain relief, so it makes everything a little bit more complicated. And the other thing that we're going to talk about is a little bit about patient advocacy. We are advocates for our client, and you'll hear that all through the course, and you should have already heard it now. We are there for our patients, we are there to support them, and we are there to get them the best quality care that we can give them. And of course, part of what we're going to talk about is the contribution to nursing care of clients with common disorders, but with complex needs. So, performing nursing interventions is actually what we have to do when we do an intervention, which means we take care of someone, we care for them. We have to consider lots of things. So we need to consider our patients' needs. Physical, so their size can vary. What type of bed they have can vary. What are their needs for that bed to be comfortable? Okay, psychological. So it could be things like social isolation if they're in hospital, because some people at a certain age don't like visiting hospitals. Because the old story is, once you go in, you never come out. And of course there's the religious requirements we have to think about. And different faiths pray at different times. Whether it be pointing towards Mecca or whether it be the need to go to church on a Sunday. They're all important to our clients, and we have to consider them. So, and the other thing that we need to do when we do interventions is encourage our patients to participate in their own care. Why? Why do you think we do that? Well, we want them to become active in a hospital or in a home setting. We want them to be able to do as much for themselves as they can. It's about dignity. It's about exercising to be able to do those little things, keep you moving. If we sit a client in a chair and we wash them and we feed them, that's what they're going to do. They're going to sit there. Their muscles are atrophied. They won't be able to go and do things for themselves. So then the care becomes more and more and more. But if we can get them to walk up to the kitchen table each time we go to organise their food, it's dignified, it's respectful, and gives them a little bit of exercise and keeps those muscles going. So we need to tailor our care. What interventions we do need to be tailored to that client's needs. There is no point in going in and giving someone analgesia if they haven't got pain. Okay? So we need to be tailoring what we do for them to give them the optimal amount of care. And of course, a really important thing is privacy and dignity. Now, in later units, we'll talk about domiciliary care and care in the home and the need for privacy. How much information does that person want other people to see? So that means where do we leave the file? That's their privacy. In hospitals, we can't paste above a person's bed, intellectually impaired, diabetic. It's not allowed because that's privacy. And dignity is about respecting their needs, respecting that People can be grumpy and not using derogatory terms towards our patients, whether it be in the patient's earshot or not. If we keep our own dignity in relation to our patients, we can keep our patients' dignity. And that's really, really important. It's from the heart. Okay? I really think when you'll hear it all the time, perform that within our scope of practice and our get out of free clause, follow the organisation's policies and guidelines. You'll hear it, we talk about it all the time because everything varies in every different hospital, nursing home. They all have a different scope for different members of the nursing team. So we need to be aware of that. And we need to document what we do. So if we do an intervention, and this is a really good hint for those that are going to do Oscars down the track, if we do an intervention, right, we need to follow up that intervention to see if it's been effective. So we do an ECG on someone with chest pain, we need to go and see, we need to do a follow-up ECG when they don't have pain. Or we give them some pain relief. We give them 2 milligrams of morphine because they've got 8 out of 10 chest pain. What's the point of giving them morphine unless we go back and see if it's worked? So we come back and say, how did that morphine work, Mr. Smith? It's down to 6 out of 10. Okay, we might need to give him a milligram more, but if it's gone up, we might have to look at an alternative pain relief. So we always follow up our interventions and report what's happened. So if they do get pain relief, 2 milligrams of morphine, pain now 6 out of 10. Another milligram given, pain 4 out of 10. Given 2 GTN and an aspirin, pain 0 out of 10. We need to keep reporting that. Otherwise there's no point. And also, perform nursing interventions following predetermined care plan. If we don't have a care plan, we can't provide coordinated care. And coordinated care includes all the team members. So they should be able to read our care plan. It's not a nursing care plan, it is a patient care plan. Advocacy. Mentioned that in the start. We are advocates for our patients. What does that really mean? It means that we respect the rights and personal choices of the patients, and we make sure other people do. Doctors, physiotherapists, right? We may have to remind them that Mr. Smith likes to be called Bert, or not Bob, you call him Robert because that's what he prefers. That's advocating for our patient and making them comfortable. Encourage self-advocation, encourage people to speak up. One of the things I saw recently, really great idea, is I saw signs around a hospital that says, the patient may ask you if you've washed your hands. And it says there's nothing wrong with that. And they are entitled to wash that. If you come in from another place, they don't know where you've been, don't get offended if they ask if you wash your hands. They're protecting themselves, they're standing up for their rights. And I thought it was just an excellent sign. Okay? So, identify and address a conflict of interest. What could that be? Classic. And I used to call them NFRs, but your living wills. What does this patient want in the way of resuscitation? Do they have the right? And can we ensure their right? Is that a legal right? So we need to advocate for our patient for their choices. Consult and collaborate with the appropriate personnel to develop and implement strategies to address the client needs. So who are we talking about there? Other team members. So what's a good time? When does this patient function the best? 10 o'clock in the morning. He's always awake, alert, and wants to get out and move around. You get to 4 o'clock in the afternoon and he doesn't feel like it anymore. He's tired, he's worn from the day. He's had all the visitors come in. Along comes the physiotherapist and wants him to go for a walk. Not only does he not want to walk because his relatives are all there, because he wants to talk to them, right? He's tired. If she'd come in at 10 o'clock in the morning, he would have gladly done it. And so we can talk to the physiotherapist about it and say, look, I've noticed when Mr. Smith is about 10 o'clock in the morning, he seems to be at his peak. If you could possibly get here around that time, he might actually do a bit more for you. He won't be grumpy, he won't be resistant, and he likes to go for a walk in because that's what he's done all his life. So stick up for our patients, be supportive. I've seen the videos work. One more try. Okay. It works when you want to.
Nurse-patient advocates. As a nurse, being a patient advocate means to defend the rights of and be a supporting voice for the patient. This is broken down into two parts. Actively participate in patients' care by supporting their rights, communicating healthcare needs to their medical team, and provide information to the patient to assist them in making decisions. Participate in the broader efforts to improve the healthcare environment, safety standards, and quality of care for patients. Being an advocate is a vital part to being able to provide quality care because patients who are ill or injured are often too scared and vulnerable to think as clearly as they normally would. Because of this, they can neglect to ask follow-up questions to their doctor, leave out important health information on hospital forms, or agree to procedures that they are not entirely comfortable with. A nurse-patient advocate fills this gap by helping patients know what questions to ask, conduct follow-up research on the patient's behalf, and communicate decisions by the patient to their medical team and family members. Advocacy as a nurse also includes looking out for the patient indirectly. When in the role of a patient advocate, a nurse will routinely review medical charts to look for any errors or dramatic healthcare changes. Doing this can catch potential problems in advance. For example, if a prescription drug is scheduled to be administered and the nurse senses that the dosage amount is incorrect due to a data entry error, he or she will act as a voice of the patient and do the due diligence needed to confirm the dosage amount before administering it to the patient. Advocates also play a large role in patients undergoing surgery. Their job is to make sure that patients fully understand the scope of the surgery, where it is being performed, recovery time, and any complications that may be involved. Their role isn't necessarily to explain those details to the patient, but to make sure that the patient has received those details from the doctor or surgeon, and that they have had all their questions answered before the scheduled surgery time. Communicating with patient family members is another significant role for advocates. These are times when a patient is not comfortable sharing healthcare choices or medical information with family members. An advocate will act as a liaison to family members on such topics or relay information from the patient when family is unable to visit the patient directly. To summarize, all certified registered nurses are expected to incorporate patient advocacy into their practice. Nurses have gained a reputation as being the most trusted voices of the healthcare industry because they truly represent the sick and injured that look to them for help and healing. Through advocacy, nurses can serve their patients better and play an active role in their recovery.
So, what I mentioned in there, it was really important, is that we are aware of what we need to do as nurses and advocates for our patients. So, I think that's a great little video about advocacy, and it's on YouTube. Look it up. It's really a good one if you want to rewatch it. So, the video talked about how we contribute to their care. Advocacy is part of it. So, we have to provide appropriate and specific care to meet their needs for specific conditions. So, we don't give someone something for pain, like I said, if they haven't got it. Right? So if they're in pain, we give them something. We give them pain relief. So we need to monitor appropriately. There's no point in doing neurological observations if we know what the outcome's going to be. If they've got a GCS of 15 and they're active, alert, and running around the ward and visiting, why are we doing neurological observations? Why? So we look at their chart and go, oh, it's got neurological observations charted. In being an advocate also and making sure that we're not wasting our time and giving them the best care, we can ask that they be taken off. Speak to the doctor, do we really need these? There might be a reason that they're on there, but there also might be a reason, the fact is that they've transferred it on the care plan and no one's thought about taking it off. Okay? Refer the RN to any reactions or abdominal responses to the outcomes of your implemented care. So if you do something and it's not normal, you're doing a wound dressing that normally is not painful and they start screaming in pain, find out why. Tell the RN, get them to come in and have a look and decide. If they stop eating their food or they're not drinking enough, tell the RN. So, lots of common disorders that can become really complex. Okay, so there are musculoskeletal conditions, and we'll talk about a few of them in a few later slides. Skin disorders, respiratory disorders, blood disorders, diseases of the cardiovascular system, conditions of the nervous system, infectious diseases, vascular disease, gastrointestinal disorders, endocrine disorders, reproductive system disorders, and urinary system disorders. They can all be not just one simple thing to fix. They can lead to other things. So a prime example is reproductive. Person can't have a baby. So think about the psychological effects on some people that could have. They try IVF, they fail. It's a huge thing that we need to consider about depression in there. What supports can we get in place for them? How can we help them? So it's not just a matter of, they didn't get pregnant this time, she'll be right. They might not be able to afford it for the next time. Unless we know those things, we can't support them. So nursing interventions. So they include assistance with their activities of daily living, medication, allied health referrals. If you think your patient needs a referral to a physiotherapist, as an enrolled nurse, you can talk to the RN or you can talk to the doctor and say, look, can we get a referral to the physio, please? I've noticed Mr. Smith not walking as well as he used to be, we might need to get a better type of walker for him. They will listen to you. All right? If they don't, they're foolish. But most doctors know that the nurses deal with the patient most of the time. Don't be afraid to ask. And if it becomes an issue, talk to the RN and they'll talk to the doctor. Observations. Changes in observations we need to record and report. Procedures. So we'll do lots of procedures, whether that be wound care, whatever. We need to say what we see, describe the wound, and tell someone about it. If it's got yellow slough in it, as we heard from our wound care one, or slough as I like to call it, pus, we need to consider what we need to report. So that's part of what we do in interventions. Okay? In musculoskeletal conditions, as you can see, fractures, they can be open or closed. So if it's an open fracture, it's not just the fact that they've got a broken bone, it's that they can't move. They then have a wound because the bones poke through the skin and you've got a risk of infection. How did they get it? They came off a motorbike, so that's a greater risk of infection. Okay? Arthritis. Right? It's not just the fact that they have arthritis and they can't close their hands properly. Pain. Huge issue in people with arthritis. Whether it be osteo or rheumatoid or septic arthritis. So, gout. It's a painful thing. We'll have a little bit of thing on gout shortly. But gout can lead to other things. Social isolation because they can't walk. Pain. So it's more than one thing. Osteomyelitis. Rhabdomyolysis. We'll talk about rhabdo shortly. But everyone's going, what's he mean by that?
And so
Do you want to pause?
You're large.